Okay, Michelle Bullock, licensed massage therapist here, and we're going to be talking today about muscles that you need to know for the MBLEx that are in your head and your neck. We're going to be talking about the muscle itself, we're going to be talking about the attachments, and we're going to be talking about the actions of each muscle, but we're not necessarily going to be talking about any kind of pathology, range of motion testing, or anything like that. We're just going to be talking about the muscles that you need to know so that you don't feel overwhelmed. Oh my gosh, there's so many muscles that I need to know. It's actually not that many for each section of the body. You don't need to know all the muscles that you could possibly know, just an important selection of them. Just a little bit of housekeeping. I want to mention that I have some free resources for you in the description below. I have a practice test, a 100 question practice test, so that you can see where you're at in your studying and get some practice doing 100 questions in 110 minutes. The more times that you practice that, the easier it will get and the less likely it is that you're going to freeze when it comes to finishing that test in the amount of time that you've got. In the packet for the practice test, I have complete answers for each of the questions, and then there's a topic key at the end where you can circle the questions that you missed and find out areas that you need to spend more time studying and which areas that you can back off on so you don't overstudy and you're not questioning, oh, what have I missed? And then I also have a complete study guide that will tell you what you need to know for the MBLEx, section by section, created by the Federation of State Massage Therapy Boards, broken down into a much easier format to understand. It's in a printable PDF form, and so you can just go and check off everything that you've studied as you go. And then finally, I have a mini course about how to apply for the MBLEx, because there are multiple steps that are involved with applying for the MBLEx. That's going to be in the description below. It goes through and it explains what the MBLEx is all about, the application process, what to expect on test day, so on and so forth. So make sure and get those freebies, and then we're going to get on with the program here. First thing we want to talk about is the important landmarks. I'm going to put a clip in here from my Complete Anatomy app that will show you where all those landmarks are on the jaw and on the head and on the cervical spine and on the thorax. But first, we're just going to start with talking about the head landmarks. We've got the mastoid process, which is going to be behind the ear. You can palpate the edge of the skull behind the ear, very gently, of course. You can find that edge of the skull where it comes down behind the ear. That's going to be your mastoid process, and you can just run your fingers up, and it feels really good because you've got some important attachments in that area. So we got the mastoid process. We've got the superior and inferior nuchal lines. When you reach up, you can feel a bumpy bump on the back of your head. You can see me going bumpity bump over it. So this is the big bump is the superior line. The smaller bump is going to be the inferior nuchal line. I hope you can hear me with my back turned to you. The inferior surface of the occiput of the occipital bone is not something that we can actually palpate on ourselves because it's actually going to be inside. So I'm showing it in this app that the place where it's at is, if you palpate the place where your cervical spine goes up into your skull, it's going to be around on the anterior side, deep inside. The Galea aponeurotica is this big fascial sheet that goes over the top of your head, and you've got a few muscles that attach to that. So that is a landmark. It's not a bony landmark, but it is a landmark. I can slide it around. Just a little quick story. One of my sons was running around. He was 5 years old, and he was running around with his older sibling and flew into a really sharp boulder head first, because that's how they roll, and it created a big gash in his head. And then we went to the urgent care clinic, and the physician thought it was really interesting to be able to pull that apart and be able to see that fascial layer. So it wasn't like I was looking at his skull, I was looking at the fascia, which was like, it's just how you imagine it, how it's drawn in all of our anatomy books, is that it's fibrous white tissue that covers the skull. And that's where a lot of the pain actually is coming from when we have headaches and such, is from that tissue. And then we have the mandible, which is your jaw bone. So we can feel where it attaches to the head part itself, and we can feel all the way around. So there are different spots that are important, meaningful on the mandible. We've got the neck, we've got the ramus, and we've got the angle. So the neck's going to be up here, the ramus is going to be in there, and then we've got the angle, which is that chiseled jawline on the side. And then we have this outside part. We got the zygomatic arch, which is our cheekbone. That's the zygomatic arch. We've got important attachments there. Temporal bone is on the side, on the lateral sides of the head. So we've got some attachments, like the temporalis is going to be attached to the temporal bone. And then we've got the stylus process, which is also behind the ear, but we're going to be moving a little bit anteriorly and a little bit inferiorly to a little gap. We're going to be super gentle with this spot because it's very fragile, little sticky outy that has some attachments. So stylus process. Moving on to landmarks of the spine, we have, of course, the cervical spine. We have the spinous processes, which are the little bumps that go right down the center. So we have spinous processes that form attachment points. We have, of course, the transverse processes. So if we slide our fingers laterally, we'll feel like a curve in the bone, in the cervical spine, and then we feel like the points of the sticky outy. And those are all the way over on the lateral side. They're way over on the side compared to being on the back. So as you go further down the spine, those transverse processes are going to be sticking out more posteriorly, but they stick out way laterally on the cervical spine. And then we have the anterior vertebral bodies. When we see a description of the insertion or the attachment points being in the vertebral bodies, that means in the anterior areas, in the front of the cervical spine is where we're going to have some attachments for specific muscles that are in the anterior aspect of our neck. When we go to work on the muscles of the hip and pelvis, we'll see that there are some attachment points to the vertebral bodies of the lumbar spine. But yeah, we've got some attachments on the front here as well, on the front of the neck as well. We've got attachments to the atlas and axis going back to the cervical spine. So the atlas is going to be the top bone. C1 is the atlas. And it's a really strangely shaped bone. And then fitting inside of that is the axis, which is C2. And they're just really special because they're different. They're shaped differently than the rest of the cervical vertebrae. And so we've got different attachments on different parts of those two bones. Now, as far as like spine or throat attachments, I believe that the hyoid bone is a really fascinating thing. It's this floating, strange bone that helps form attachment points for our swallowing and our speaking. So if you reach in, if you just like gently palpate your throat, you feel some bumpy bumps about in the middle of your throat. That's going to be your thyroid. That's another place where we have some attachments, is the thyroid. That's just like, it's not quite bone, but you can feel that there's something there. So that just hangs out in the front. And then just above that, there is an actual bone. And because it's got a lot of muscular attachments, it doesn't feel like a bone, but you can actually like move it around. It's really soft and small. It's going to be right below the jawline and above the thyroid. And if you hold it and go with your tongue, you can feel it move, slide up and down. That's the lateral part of the hyoid bone. As you feel more inward, you can actually feel the little tiny ridges of the hyoid bone. Now, I've done some really fine, specific, targeted work working on people who have a lot of tension in the anterior part of their neck. And I've actually been able to release trigger points in people's hyoid bone, but you have to be super, very, very tiny, very careful. But it's pretty fun to think that there's all these tiny little muscle attachments that happen in this floating bone. So they're pulling back and forth It's like puppet strings pulling back and forth on this tiny little bone, and it's really cool. Now for your thorax attachments, here's your clavicle that's got some attachments, and then right in the middle, we've got the manubrium of the sternum. So that's that top bone of the sternum. So we've got some attachments that go there and then go up the neck. And then we've got the first and second ribs, but for the head and neck muscles, those attachments are going to be inside of the clavicle in this little divot between the neck and the shoulder. You'll be able to just carefully reach in under the clavicle and feel where there are some muscle attachments that are happening on that rib right under the clavicle. First and second ribs. Actions that the head and neck are capable of, besides facial expressions, and I'll talk about that later on. But for the cervical spine, we've got flexion, extension, rotation, and lateral flexion. So we talked about all of that in the spine and thorax video. When it comes to movements of the spine and thorax, that also pertains to the cervical spine as well. So all of the movements in the mandible, in the jaw, are going to be at the temporomandibular joint in this area right here, okay? And that helps us to be able to speak and to masticate, to chew. So the movements that we have are depression, we have elevation, where we shut it, we have protraction, where the jaw sticks out, and we have retraction, where the jaw pulls back. We have muscles that do all of those things. Okay, so let's just go ahead and get started going through the list of muscles that you need to know. First, we have sternocleidomastoid, SCM for short, because sternocleidomastoid is a mouthful. Sternocleidomastoid has two heads. The origin of the sternocleidomastoid has two heads. We have the sternal head and we have the clavicular head. Sternum, remember that's in the center, and the clavicle, which is a clavicular head, right? Sternocleido, bump, bump, bump. So that the top of the manubrium is where one attachment is. And then we have some, like a broad attachment along the internal surface of the clavicle. And then it inserts in the back of the head at that mastoid process we talked about. So with that origin being fixed, then it's going to rotate your head contralaterally. Remember, we talked about that in the video on movements of the spine and thorax. Contralaterally means you're going in the opposite direction from the side that the muscle is attached at. So it brings you, because its attachments are like this, it's bringing your jaw forward. So the actions that it is responsible for unilaterally is flexing the head sideways, contralateral rotation. Bilaterally, it's going to flex your chin toward your chest at the cervical joints. Next, we have the scalenes. We have three scalenes, the anterior, middle, and posterior. I'm just going to point those out. Anterior, middle, posterior, this little one toward the back. But we're going to go through each one. The anterior scalene is going to originate toward the anterior part of the transverse process. So we're going to come around the side just a little bit. These tiny little palpations can make a huge difference with you being able to understand how these movements work. And then the insertion for the anterior scalene is going to be the first rib. So they're like little webs that go 3, 4, 5, 6. Yeah, 3, 4, 5, 6. And then they come down and they web across the first rib under the clavicle. So the actions of the anterior scalene are unilaterally, one side, with the ribs fixed. That means that the ribs are going to pretend to be the origin, and the actual origin is going to pretend to be the insertion. So it turns the head in the opposite direction, contralaterally, just like the sternocleidomastoid, okay? But it's also going to laterally flex to one side. But then when the cervical insertions, the cervical origin is fixed, then unilaterally it's going to bring the ribs up for forced inhalation, okay? So to help you to be able to breathe, and also it helps you to be able to flex your neck bilaterally. The middle scalenes is going to have the same actions as the anterior scalenes, and it's also going to have the same insertion, which is the first rib. But in this case, the middle scalenes origin is going to be on the transverse processes of the 2nd through 7th, so it's got a broader area that it originates from. Its location is going to be more on the tippy tip, the lateral tippy tip of the transverse processes. Unilaterally, one side, its job is more about lateral flexion than it is contralateral rotation, but it still helps with both. And then finally we have posterior scalenes, which also elevates the ribs during inhalation. It attaches to the 2nd rib, so it's going to be deeper down. It's going to be more in the back because it's posterior. Its insertion is going to be deeper into that 2nd rib down below. And then it's going to be on the more posterior side of those transverse processes from the 6th and 7th cervical vertebrae. So it's going to be down toward the base. And it's more about lateral flexion. It does help rotate the head and neck to the opposite side, but it's not very much about that when it comes to unilateral. It's because it's toward the back, it's not going to be really helping with flexion of the neck. It's mostly about inhalation when the origin is fixed. Okay, so I didn't get a chance to talk about the suboccipital muscles in the spine and thorax section, but I wanted to keep it for the head and neck because I associate it much more with head and neck because all of its attachments are on the base of the skull. And they're just so small. I feel like they're very intrinsic to the neck. So that's why I wanted to save it for this section. There's 4 of them, but I like to break them into the rectus capitis and the oblique capitis. Superior and inferior, major and minor for those. So rectus capitis posterior, as opposed to anterior, because there is a rectus capitis anterior that you don't really need to know about for the MBLEx because it's so obscure. We're not going to be massaging those muscles. But the rectus capitis posterior is really important for massage therapists because suboccipitals in general can be pretty problematic for people with muscle tension and headaches. So there's major and minor for those. The major attaches to the spinous process of the axis, and then the minor attaches to the posterior arch of the atlas. And they both attach to the inferior nuchal line of the occiput. So what they're both responsible for is rocking and tilting the head back into extension. So it's like it can rock and tilt the head, and it can bring the head back into extension. If you were to stabilize your cervical spine and just rock your head back, your suboccipitals are really responsible for those tiny movements when you have your neck completely stable all the way up at the superior as possible. So that's what those guys are for. And rectus capitis posterior major can rotate the head to the same side. Okay. The main thing to remember about all the suboccipitals is that they're mostly responsible for doing little head tilts, doing very subtle head extensions, and doing very subtle little tilts. That's the most important thing to remember when it comes to the action of the suboccipital muscles. They're much more important when it comes to just knowing where their attachments are, because people get a lot of trigger points in those muscles, especially in the wake of a whiplash incident. So the other 2 suboccipitals, or the oblique ones, they both come down and attach in one way or another to the transverse processes, the transverse process of the atlas, but they do it in a different way. So the oblique capitis superior has an origin at the transverse process of the atlas, and then the oblique capitis inferior has an insertion at that same point, and they V off. So the superior one obviously is going to be attaching to that nuchal line, and then the inferior one comes across and attaches to the spinous process of the axis. So that's a lot to remember. But what I try to do when it comes to the suboccipitals, when I'm palpating somebody, is I feel at that nuchal line in the back, and I feel across to the transverse processes, and then I create a little triangle that comes into the spinous processes. And in that area of the axis and atlas up to the nuchal line and across to the transverse process of C1, C2, this is the suboccipital zone. And so that's an area to focus on when you're working on those suboccipital. The specific details of each of these muscles isn't that important for the MBLEx. It's really unlikely that you're going to get specific questions about the origin, insertion, and actions of those muscles. What's more important is that you understand the pattern and the big picture. And so that's why I'm bringing you these teeny tiny little obscure muscles, just so that you know in groups what's significant about them to help you to be able to remember for the MBLEx. So now we're going to be moving from the posterior aspect of the head and neck, and we're going to be going to the anterior, all these front of the neck muscles. And the most superficial of all those tissues is the platysma, which kind of isn't a true muscle, and it's more like a fascial sheet, but it is significant because it has general origin and insertion, and it does help to articulate our head and neck. So it helps to depress the mandible, open, oh, that was awful, and it helps to tighten the fascia of the neck. When we do this, we can feel it get tight. We can actually feel the tissue, the fibers. When we do this of the platysma, and it draws down the corner of our mouth. This is the origin in this area right here across the superior part of the pec major, which is the most superior chest muscle. And then it comes up and attaches at the base of the mandible across here and the skin of the lower part of the face. So it's the most superficial tissue. It feels really good to stroke it. Okay, so going in deeper into those cervical flexing muscles. Under the thyroid and the hyoid bone, you'll find teeny tiny little muscles. They're very much like the erector spinae muscles of the posterior neck, but they're on the anterior part, and they help to do the little flexions. And I actually was trained in massaging them. So if I reach in very carefully, you can do this on yourself as long as you're very gentle, and you just reach in very carefully under the thyroid, and you can carefully put your fingers in. Take a deep breath. You can feel the front of your cervical vertebrae, and that's where those attachments are at. So the longus capitis, we're going to take this apart. Capitis means head, right? So we know that muscle is going to be attaching to the head, and in this case, it's going to be on that inferior surface of the occiput that I showed you, on the base of the head, but on the anterior part, on the right way in the middle of where the cervical spine attaches to the head. And it comes down to the transverse processes in the front of C3 through C6. So about in the middle, right there, and it comes and it goes up in there. So longus capitis isn't one of the ones that I massage very often. You can, but it's a lot harder to get to. I like longus colli, or longus cervicis is another name that you could use for that, which is C5 through T3. That's the inferior one. That's the one that I work on a lot more when somebody has whiplash or some kind of cervical strain, chronic tension in the front of their necks. And so bilaterally, both the longus capitis and longus colli will flex the head and neck, of course, but also unilaterally it flexes the head and neck to the same side and rotates the head and neck to the same side. It helps with those. Yeah, so the origins being the bodies of C5 through T3, so deep in there, not on the transverse processes, but deep in there, attaching to the cervical bodies. And then the tubercle of the interior arch of the atlas, so it's going to be in that anterior area of the cervical spine. And it doesn't attach to the head, it only attaches to more of the vertebral bodies and transverse processes of the cervical spine in the anterior aspect. Okay, moving away from the front of the throat, we're going to be talking about a couple of head muscles. We've got Occipitofrontalis. So we talked about the Galea aponeurotica. That's that fascial tissue that's on the front. It helps to stabilize the Frontalis muscle, which helps you to be able to raise your eyebrows, wrinkle your forehead, act surprised, oh my God. The attachment being the skin above the eyebrows, the frontalis, that's the origin. And then its insertion is going to be on that facial tissue, and it helps to bring those tissues together. Okay, so we have that, and we have the occipitalis part, which originates at the superior nuchal line, and it also attaches to the galea aponeurotica. So it's going to be right in there. And it helps to pull your head, your scalp muscle back. Feels really good when you massage it too. Doesn't seem like we ever do it, but it does pull there are times when when our whole scalp like pulls backward. Masseter, that's the main chewing muscle. That's like the most superficial one. This one we always think about. It's going to be originating at the zygomatic arch and inserting at the angle and ramus of the mandible, and it helps to elevate your jaw at the temporomandibular joint. Another superficial muscle that's very important to the head is the temporalis, which is also very much involved with TMJ, the temporal mandibular joint. So it's going to be originating in the temporal fossa. So there's this like divot in the bone, and it just has all these tiny little attachment parts, little attachment places, all inside of this divot in the bone, and it comes down and it attaches to the anterior edge of the ramus of the mandible. So it goes and it comes down and attaches to the mandible, and it helps to elevate the mandible and retract the mandible, pull it back. So it brings it up and back. So that's important. What helps to elevate that jaw? Helps you to crunch your jaw, helps you to close your mouth. Temporalis and masseter, very important muscles. Okay. So pterygoids, PT, pterygoid. We have medial and lateral. They're like the suboccipitals, but in the jaw. And they're tiny little muscles that are inside, under the mandible, that have little attachment points on little spots inside the skull and attached to different places on the mandible to help with elevating the mandible and protracting the mandible. So bringing it up and also sticking it out. So up and out. Lateral deviation, which we haven't talked about yet. That's another thing that I should have put on that. The actions of the jaw is lateral deviation. Pterygoids are responsible for that. I'm not going to talk in any more detail about the attachment points for the pterygoids because they're not going to be that important. Just know that generally the pterygoids attach on the inside of the jaw and help with those TMJ movements. Okay, we're going to talk about the hyoid muscles. Remember I told you about the hyoid bone that's in here, right? We have two sets of muscles. The first set is supra, which is above the hyoid, and the second set is infra, which is below the hyoid. And they have attachments all around the head and jaw and come down and attach to the hyoid bone. And they have attachments from the hyoid bone and attach all over the clavicle and the sternum and the thyroid. And all of these muscles are for either mastication or for speaking, making different kinds of sounds with our throat. So going one by one. Now, you might remember when we were speaking about the muscles of the forearm and hand that these muscles have the names of the attachments built into the name of the muscle. So that's the thing to remember about knowing what muscle your MBLEx question is going to be talking about, is that if you slow down, there's a pretty good chance you can figure out what area of the body this muscle is referring to and what that muscle might do. The first suprahyoid we're going to be talking about, above the hyoid that we're going to be talking about is the stylohyoid, which originates at the stylus process, that little sticky outie, posterior to your jaw and inferior to your ear, the stylus process, and it comes down and attaches to your hyoid bone. And it helps to elevate that hyoid bone. It helps to elevate the tongue. And also, if the hyoid is fixed, then it's going to depress the mandible. Bring your jaw down. Stylohyoid, hyoid stylus process. There you go. And two other suprahyoids would be the mylohyoid, which goes from the mylohyoid and the geniohyoid are both attached to the inside of your jaw. And so those aren't, the hyoid part is clear that it attaches to the hyoid bone, but the mylo part and the genio part, they both just have to do with little names for or originating at the jaw. So they're both under that jawline, and they help to elevate the hyoid and depress the mandible. So I'm not going to open my mouth big, so it's going to pop again. And then a suprahyoid muscle that doesn't have the same kind of attachment, so it has a different kind of name, is the digastric muscle. And what's significant about that, digastric, means it has two bellies. So that's something to remember. Two bellies. It does this really weird thing where it goes from the mastoid process, comes down to the hyoid bone, and goes up to the inferior border of the mandible. It has one belly between the inferior border of the mandible and the hyoid bone. And it has has a little strap that it goes through, and then it comes up and attaches to the mastoid process deep under the splenius capitis and the sternocleidomastoid. With the hyoid bone fixed, that means the hyoid bone is staying in place. It helps you to depress and retract the mandible. And then with the mandible fixed, it brings the hyoid bone up, which helps with making different kinds of sounds in your throat. Those were the suprahyoids, stylohyoid, mylo, and geniohyoid. And then we have the digastric. And so when you think about where those different attachments are, it helps you to be able to figure out what is going on with the jaw and the throat. And so for the infrahyoids, those are the ones from the hyoid bone down to the thyroid or the clavicle. Pretty much they're very clear about where these different attachments are. So we've got sternohyoid. It attaches from the manubrium, which is the sternum, up to the hyoid bone. Helps to depress the hyoid bone. So because they shorten up, shoop, the hyoid bone goes down. The next one would be sternothyroid, which goes from sterno, that's the origin at the top of the manubrium, which is sterno, right? Thyroid cartilage, in here, it depresses the hyoid bone and the thyroid cartilage, so it brings those down. So it's another one that does that. And then we have thyrohyoid, which goes from the thyroid cartilage to the hyoid bone, and it helps to depress the hyoid bone, helps to bring that down. And then the fourth one, which is a really strange one, is called omo. I think omo refers to the scapula. Omo refers to shoulder in Greek. So omohyoid is from the shoulder to the hyoid. Isn't that strange that such a muscle exists? But it's got a couple of bellies, and it goes from the superior border of the scapula and it comes up to the hyoid bone. So if you feel a little poppy pop, it could be, like especially in here, it could be that omohyoid, and it depresses the hyoid bone as well. All right, so those are the most important things that you need to know when it comes to the muscles of the head and neck. So remember your medical terminology when it comes to the hyoid, sterno, stylo, occipito. Those are referring to specific areas around the head and neck, which will help you to be able to remember what kind of movements, what kind of actions are involved with those. But real quick, I want to talk about facial expression muscles that you were probably not going to be tested on, but I still want to talk about it anyway because it's really important just in case, because you never know. My neighbor is being very noisy. My neighbor in the shop that I'm working at is being very noisy right now, and it's a little bit distracting, but I'm doing my best to hang in there. So what's really important is to remember that medical terminology when it comes to the oris muscles, which is referring to the mouth. Oris, orifice, right? We've got orifices. So oris is the mouth. An orbicularis type muscle is like a circular one that acts like a sphincter, so makes you do that. And you also have oculi orbicularis that helps to squeeze your eye muscles. So orbicularis is a circular shaped muscle that squeezes in. And so we have oris and oculi. Oculi are your eyes. And then we have auricularis. So we have auricularis, not orbicularis. Auricularis, which is A-U-R, is referring to the ears. Let's go over this again. Oris, oculi, auricularis, A-U-R. And then we have zygomaticus, which is everything that has to do with the cheekbone, all the little muscles that have to do with the cheekbone. And yeah, that's it. Oh, labii, lips. So with all the different facial expressions that we have, all these tiny little muscles, and we have to remember labii is lips, oris is mouth. What about nasal? We got nasal muscles. It's not important for the MBLEx. Oculi, zygomaticus, and auricularis. So when you see a question like that on the MBLEx, which is highly unlikely, then you know it's going to be referring to that, and it's more about understanding medical terminology than it is about memorizing the articulations and insertions of those specific muscles. So that's going to do it for today. If you have any questions, make sure and put them in the description below, and make sure and get your free resources that I have available. Practice test, study guide, a free mini course about how to apply for and prepare for the MBLEx. Those are all free for you down below. And also I have a 10 test bundle that's available for purchase so that you can practice over and over again to be ready for that test. Set a timer and just do it. 100 questions per test. It ends up being 1,000 questions altogether in that packet. And so with that, make sure and subscribe. Make sure and watch all the other videos so that you can best prepare for your MBLEx experience. I'm doing what I can to get as much information out as possible to make life a lot easier for you all. A lot easier than it was for me when I was trying to take the test. And I will see you guys in the next video. Toodaloo.